Thank you for the organizing committee. My name is Ahmed Raslan. I'm the professor and interim chair of neurosurgery at Oregon Health and Science University, and I will be speaking to you today on the principles of neuromodulation. Neuromodulation is defined as the alteration of nerve activity through targeted delivery of a stimulus, such as electrical stimulation or chemical agents, to specific neurological sites in the body. Neuromodulation is in contrast to the concept of neural ablation. So neuromodulation is reversible, and it could be achieved either pharmacologically, like you see on the upper left, or electrically, as you see on the lower left, versus neural ablation, which can be done in various forms to the spine or to the brain. And here are examples of ablative procedures that are commonly performed using radio frequencies, such as myelotomy, trigeminal tractotomy, cordotomy, and DRES. If you are trying to classify the types of neuromodulation, depending on how invasive they are, you could classify them into non-invasive methods, such as repetitive transcranial magnetic stimulation, or ultrasound, focused ultrasound-based neuromodulation, or invasive. And based on our location, neuromodulation could be delivered either in the central nervous system or in the peripheral nervous system. The method of neuromodulation, the most commonly used method is electrical, but also pharmacological neuromodulation in the forms of pumps. The delivery is possible, and as we spoke about, sonic or optogenetic. First, let's start about the concept of oscillations versus frequency band versus spikes. These are oscillations, and oscillations usually reflect a repetitive revolution of activity, and neural activity could be in the form of oscillation. However, most neurons do not actually function this way because the action potential has an absolutely refractory period. So there is a time in which there is no neural activity between each wave and the following. Consider each action potential to be a wave of sort as waveform. On the other hand, these are frequency bands. Frequency bands are a different concept. They still use a frequency, and the frequency here is the number of beats per minute, but these reflect the aggregate activity of neural signals. So they are measured from EEG or could be measured from the brain. And the frequency band, they're named based on the discovery. So the alpha wave was discovered first, mu got second, beta, and there's gamma, and there is the delta. Now spikes, and spikes represent the way actually neuron works. So in contrast to revolutions and oscillations, neurons function this way. There's an action potential, and then there's a silent period. And most neuromodulation devices deliver their neural signal in this format: rectified bipolar waveform, or sometimes tripolar waveform, followed by a period of silence. And this would be a regular, and the reason this is regular is because the interspike interval, the interval between one, at the end of one waveform and the beginning of the other, is a constant. And the pulse width, which between the beginning and the end of a waveform, is also constant. And T is the time, which is the addition of interspike interval followed by the pulse width. And frequency is 1 over time. So it's important to remember the concept of interspike interval. And the interspike interval could be very long or could be very small. And if you know the time in frequency in hertz equals 1 over time in second, then this waveform. Another concept is the biphasic waveform, which is the one on the right upper, in which the anodal phase upward and cathodal phase are both exact and equivalent and similar, and this is what's called active charge balancing. We need to charge the net balance to balance the net charge to not injure the nervous system when we deliver electrical stimulation. There is also another way of DBS in which there is passive charging, in which there is no cathodal phase, or the negative uses the multiplexing format such as the DTM we'll get to. The shape of the waveform could be made rectangular or rectified bipolar, or rectified bipolar with an interphase gap, pseudo-monopolar, triangular, or Gaussian. This is a waveform that has an intra-burst rate of 500 hertz, and it has a bursting rate of 40 hertz, and a pulse width of 1,000 microsecond and 5 pulses per burst. This is the burst DR waveform. Anything less than 0.5 hertz is called intermittent slow oscillation, alpha 7.5 to 13, mu and delta 13 to 30. And gamma is above 30, and we use these waveforms for certain descriptions that I will get to you. Conventional EEG is these waveforms that we described, and an ultra-fast waveform is up 200 hertz, and ultra-slow is 0 to 0.5 hertz. We have leads, energy source, algorithm of stimulation, and detection algorithm if these waveforms are detecting activity. This is, for example, a DBS electrode and generator, and you can see the DBS, the format of the lead is tubular and thin and delicate, and that's because it is designed to penetrate into the brain. We feedback into the implantable neurostimulator, INS, this battery or the can. And there are several manufacturers. They're not all included, but the what's so-called big three are on here: Medtronic, Boston Scientific, or used to be called St. Jude Medical. There are multiple lead choices for spinal cord stimulation, tubular, paddle, and the paddle has shapes. There's also a company called Nevro, and there's now Saluda. They all have different shapes that vary based on height and width. The charge density is equivalent to the current multiplied by the pulse width divided by the surface area. And the maximum allowable charge density that does not produce tissue damage is 500 microcoulomb per square centimeter. There's also the concept of volume of tissue activated, which is a function of the impedance of the tissue. This is here on the upper hand, see the volume of tissue activation inside the brain following DBS, and it's calculated using mathematical concepts. The pulse widths related to activation based on the diameter of the neurons. It's the wider neurons are easier to activate so compared to narrower neurons. The chronaxy, and the chronaxy is the ability of the minimum current enough to activate action potential, and that's harder to achieve in the white matter. It's easier to achieve in the brain. Mechanism of action, does it inhibit or arrest a neural firing? Well, in this example, here is a thalamic neuronal response to GPI stimulation, and in this case, DBS causes dampening or inhibition. This is the GPI neuronal response to subthalamic stimulation. In this case, it's amplification or signal stimulation. This is the effect of deep brain stimulation is modulation of the mode of firing to change it from a tonic into bursting or bursting tonic. Of deep brain stimulation for local neuronal firing in the human globus pallidus. And here we see that we could classify the responses into either stimulation that causes amplification of signal as B, no effect on the signal as A, inhibition as C, or complete arrest of signal as D. Also, it's important to know that local stimulation has more complete inhibition at very high volt. We can see that if you look at the post-stimulus inhibition histogram, that we entrain neurons. DBS also has a distant effect. Stimulation of the thalamus can activate areas such as supplemental motor area and cingulate by amplifications of the inhibitory interneuronal activity, similar to the competitive effect of rubbing or touch. Where systolic stimulation has GABAergic dependent mechanism. The burst stimulation activates both the medial and lateral pathways. The anterior cingulate cortex is connected more to the burst waveform, and the tonic does not do that. So you measure the output, and then you have a sensor, and then you feed back into the controller to change the input. That's the mathematical formula for reflection. I hope I'll be able to attend this session, but